Good afternoon, Dr. Mustafa.
Hi, good afternoon, Mustafa, Tramud.
Good afternoon, Dr. Zaki. Thank you for joining.
Good afternoon, everybody. Sorry, just a technical thing. Could you see my screen?
Yes, doctor. We can see your screen.
Fantastic. Fantastic.
We will wait for 2 more minutes.
Yeah, sure. Thank you, Dr. Zaki, for attending as well, moderating this session.
Sure.
Okay, good afternoon, all. It gives me a great pleasure to welcome you all for this today's online CME. We'll be discussing today's topic in respect to the intervention radiology. Intervention radiology has emerged as one of the most dynamic and rapidly evolving subspecialties in modern medicine. By combining the power of imaging with minimal invasive techniques, it offers targeted, effective solutions for a wide range of conditions. And one of the condition is osteoid osteoma. So for this topic, today we are privileged to have Dr. Mustafa as a speaker, our intervention radiology consultant with Burjil Medical City. And to moderate this session, we have Dr. Mohammad Zaki, our intervention radiologist consultant with Burjil Medical City. Over to you, Dr. Mustafa. And one more thing, I would like to thank you all for joining for this session. Thank you. Over to you, Dr.
Yeah.
Mustafa.
Sorry, just a couple of words. Just would like to thank you, Dr. Amul, for starting this CME. Can we please, anyone who is mute yourself, just the speaker.
للمواطن وللوطن وللسكان في كل الأقطار العربية.
Okay. So yeah, Dr. Amur, thank you very much for starting this much needed CME radiology-based diagnostic and now intervention. And we are very lucky to have Dr. Abbas. He's a UK-trained interventional radiologist. He joined us 2 years back, and he will be talking to us about osteoid osteoma. Although this is, as you know, is a benign, and Dr. Amur, he's the expert on MSK, it does really cause a lot of problem for the active young adult. And I'm very, really exciting that Burjeel Medical City has made it over the last few years from starting from nothing to now offering this service. This is a really advanced CT guided procedure. We offer it here in addition to many, many, many others. So without delay, please join me to welcome Dr. Abbas, who will take us through this exciting and important subject. Dr. Mustafa, please.
Good afternoon, everybody. Thank you very much, Dr. Amun and Dr. Zaki, for this nice introduction. And I would like to thank everybody who has joined. I know it's a very busy schedule still in the kind of middle of the day where everybody is busy with their clinic and with their other work. So thank you very much for attending this. I would try to make it simple, not very sophisticated subject because the attendee are from different specialty. So just give them some highlight about this disease. They might confront it in their normal practice. At least they have some guidelines where to go. So the topic is, as I mentioned, osteoid from a classic presentation to modern management. And today we are discussing the osteoma, which is a small yet highly symptomatic benign tumor in the bone, were first time described by Jaff in 1935. As you can see, the definition of osteoma is a benign, as we mentioned in the beginning, and it's composed of central nidus, where it is that painful part of the bone, which is composed of osteoid and moving bone, and surrounded by a reactive necrotic area. Typically, the size of it is less than 1.5 centimeter. This lesions is mainly in young adolescent age group, and this is the importance of it because it is causing them nightmare of pain, lack of sleep, and this will affect on them mentally as well as physically because they will be tired from lack of sleep. The common site of it, it's usually either in the shaft of the bone or in the proximal part of the bone near the in the epiphysis near the bone origin. And it's usually typically in the long bone, like mainly femur or tibia, but could be in the humerus as well as this commonly in the spine, the posterior element. So our goals of today's talk is to have better understanding of the tumor's epidemiology, recognizing its hallmark symptoms, and exploring the imaging strategy and comparing the treatment options that's available nowadays. As well as we have some talk about risk factor, pathophysiology, and other things. Sorry. So in terms of incidence, it's about 10 to 12% of all benign tumors. So as you can see, it's a common tumor. 10% is not a small percentage. Predominantly in male, about 2 to 3 times the female. And as I mentioned at the beginning, the big incidence in the adolescent and young age group is typically between 10 and 30-year-old. Common site, as we mentioned, usually long bones like a femur, like humerus, like tibia, in the leg, a spine, posterior element, and there has been described a rare site as well, the small bone of the hands or the foot, as well as in the skull and the jaw. In terms of there is no racial or geographic predilection, so it can happen anywhere, everywhere in the world. In terms of etiology, unfortunately, until now, we don't know exactly what's causing it. As many tumors, there are still one of these area. It is still exploring about it. But we know there are some risk factors, although genetic or environmental factor has not been clearly identified, but some studies show that like repeated trauma to some area, it may be potentially causing it. But generally speaking, it is unknown cause. In terms of pathophysiology, the most important part is the prostaglandin, and it's the key factor, a key player in this disease. And this is usually secreted from the nidus, and that's why we can see one of the diagnostic tool is response well to non-steroid anti-inflammatory drug, so the pain subside dramatically from non-steroid anti-inflammatory drug. So the nidus composition, as mentioned, composed mainly of osteoid and immature woven bone with highly vascular stroma, and this is secreting a lot of prostaglandin in that area where it's causing the pain. As a response to this inflammatory process, there will be some inflammatory reaction around that nidus, and this is causing the sclerosis and the dense bone. And this is giving the characteristic feature of lucid area surrounded by a high dense sclerotic area on the imaging. And this is one of the most important imaging factor in the diagnosis of the condition. As well as the important thing is the natural history of it, which is pain in this young age group, particularly at night, and particularly responding well to non-steroid anti-inflammatory drug or aspirin. So in terms of clinical presentation, in terms of the pain characteristic, most people describe it as dull aching. They can localize the pain, but sometimes because of the pain is severe, and these are young age group, they fail to localize the pain exactly where it is. They say pain in the leg, for example, failing to point where is exactly the pain. And as we said, mainly at night, and that's causing disturbance of sleep and this effect on the patient mentally and physically, and responding well to non-steroidal because of the prostaglandin. The functional impact of it because of the pain and lack of sleep. So these patients usually causing they will have some problem with avoidance behavior, affecting on the school attendance, affecting on the sport, affecting on their confidence. So this is how, as I said, impact on them. Particularly, they are quite young as well. So this affect on their confidence. They usually come with limping pain as well, if it's in the leg, or back pain if it's in the back. In terms of an examination, sometimes you can see swelling and tenderness, but sometimes it can be difficult because it is deep rather than superficial. Sometimes occasionally you can see some like erythema or warm at the affected area, but this is less well-known presentation. In terms of the spinal lesion, they typically come with back pain and stiffness. Scoliosis is due to the muscle spasm because long-term pain cause them to have to adapt with some position, and that may affect on the spine, particularly they are in the growing age and where any abnormal posture can affect on the bone and how the bone is going to be formed. Neurological symptoms are rare, but possible if lesion affect, for example, the neurostructure. It has been described as well. There are some of these within the joint, and that can be difficult in terms of diagnostic tool because it will cause some joint effusion, some inflammation. Sometimes the analysis is not very clear, and quite a lot of times it can be found during the surgery when they go within the joint. And this causes misdiagnosis of risk, which can mimic juvenile idiopathic arthritis or transient synovitis. As I said, in terms of the challenges in diagnosis is when the lesion becoming, I will talk more about when differentiation becoming in the borderline. So I said it's usually typically less than 1.5, but it can more than 1.5. Sometimes can be difficult to differentiate between osteoblastoma or even infection like a body abscess as well. But as I said, one of the key features are the clinical presentation, which is pain at night, the age group, as well as the responding well to the non-steroidal, in addition to the imaging modality. So as I said, one of the key features in differentiation is osteoblastoma, which is also benign, but similar histology, but larger, usually more than 2 centimeters. The thing that with this is usually less responsive to non-steroidal because there's no nidus that with full of prostaglandin, and mainly it happens in the spine rather than in the long bone. One of the other differential is a body abscess, which is, as everybody aware, is subacute osteomyelitis and can mimic a nidus on imaging as well. Stress fracture, often cortical sclerosis, but there is no nidus and there is no typical night pain. Chronic osteomyelitis can present with pain and sclerosis as well. And the most important two things are that at the bottom one is the tumor, which is sarcoma and LCH. And this need to be, particularly in the pediatric age group, this is a must need to be ruled out. If imaging cannot rule out this, it has to be ruled out by histology. So in terms of, this is our area, as radiologists, we love this imaging. So usually start with the less radiation, the cheap investigation, and the available investigation everywhere, which is an X-ray. And as we can see, the arrows there on the screen, we can see there is an area of a lucency with some sclerotic area, which is a nidus and sclerosis area. And if it is small and if the patient is big, this can be missed in the imaging on the X-ray. So the more definitive and the gold standard investigation is the CT, where we can see clearly the nidus there. This is the nidus here and the sclerotic, and the sclerotic area around it. You can see this cortical thickness, as you can see. If you compare this area, for example, with this area, you can see this is the cortical thickness, and this is the sclerotic area, and this is the typical imaging features on the CT. MRI can be also useful, but sometimes can be misleading as well because of the edema. Sometimes you cannot see the nidus. So this is like a nice comparison between MR and CT, where we can see the nidus and sclerotic area. And this is how to do it. You can see it's more edema we can see because of the inflammation on MR compared to CT. CT is usually active sclerosis rather than an edema. But here in MR, we can see nicely the edema. We can see the edema here as well and with the nidus as well. Other modality can also be useful, but it's usually more kept for if the CT is not typical, if it is the MR is not available, or we cannot do MR for any reason, or we cannot do CT as well for any reason. So sometimes can be helpful with localizing an area, but this is less specific rather than the CT because we only see like some uptake. And this could be a tumor or could be even like an infection. So it can be useful, but it is less. It has less sensitivity and specificity than the cross-sectional imaging. And the typical feature, we can see the double density sign, as we can see in the image. Ultrasound, I don't think we do much here. It's in pediatric age group. They like non-ionizing investigation, but I think in this case we can use MR. I think ultrasound can be useful, in localizing it, on if we want to do it when we want to treat it without using another radiation, we can try to do it, for example, the ablation under ultrasound guide. But this can have its own challenging as well, comparing with the cross-sectional imaging. So what's the management option that's available currently? So usually we start with conservative management, which is non-steroidal. So we can give them a trial, because sometimes this lesion can regress by itself with time in terms of the prostaglandin can get inhibited and can regress with time. So, but usually if this doesn't work, and I don't have exactly the figure about how much does it work or doesn't work, because even in the literature there is part of discrepancy about how much the conservative treatment is effective, and do the optional watch and wait. But usually we go into second stage of treatment, which is more definitive, which is a surgical. And nowadays we are moving from the surgical excision to more towards the minimal invasive treatment, which is radio frequency or thermal. I will go through what's the minimal invasive treatment next slide. So in terms of surgical excision, this is kind of old style treatment where they go and take the lesion out. The difficulties with it's invasive, has more complications. The patient have wound with their own complication, or sometimes can be difficult to reach out. So they have to expose a large area in order to reach it out. And there's about 20% risk of incomplete removal of the nidus and recurrent of the disease, apart from the long hospital staying, apart from complication with the fracture and weight-bearing bone, wound infection, and the cost of the procedure as well. So this is our talk here about it is a minimally invasive treatment, and it started with the radio frequency, and this kind of now is the current standard of care. It is safe, it's effective, it's minimally invasive, it's also cost efficient with fast recovery comparing to the open surgery. And when it starts with the frequency, we always now, whenever we say radio frequency ablation, we talk about microwave, where they are both thermal ablation, but they have the different way of delivering this temperature. And typically speaking, whenever we say microwave, that means it's more heat, less time, and bigger field of treatment. Other treatment is cryoablation, freezing. Uses extremely, we use extreme cold nitrogen to destroy the nidus. This is usually suited for lesion near vital structures, where we are worried about, for example, near vessels or nerve, when we worry about damaging from heat, because the freezing causing less damage to this vital structure comparing to the high temperature. Laser photocoagulation, less common, uses laser to ablate the nidus under imaging guide. Some studies suggest comparable outcome to RFA, but this is require more research, because one of this is a new study. We can do also what's called magnetic resonance guided focus ultrasound, MRGFUS. It's also non-invasive, no radiation, but this is also still under evaluation. So RFA, or radiofrequency ablation, usually typically we do it under CT guidance, where we insert the electrode within the nidus and we heat it up until causing a complete destruction. The advantage of it is minimally invasive. It can be done as a day case, so patient comes and leaves on the same day. Quick recovery, because there is no wound, there's no surgery. It's tiny hole, it is a pinpoint hole where we introduce that needle. And success rate is pretty high, 90-95%. And complication risks are very rare, which is kind of skin burn, affection, bleeding, pain, or recurrence, about 5%. The limitation of this is a risk of injury of surrounding structure, as we mentioned. If the lesion near a vital organ, for example, in the spine, near the spinal cord, or for example, in the pelvic bone near vital structure. But there's other modality we can use as well, which is cryoablation. It's typically done under general anesthesia or heavy sedation because introducing that temperature within the body is painful, particularly in the pediatric age group. So special consideration we have to look when we're treating a patient with radiofrequency ablation is the pediatric age group. And depends also where is the lesion. Is it the lesion near in the spine, within the joint? We need to think about if it's in the joints, any inflammatory arthritis or synovitis. Well, if it's in the spine, we have to have very good careful planning to avoid any neurological damage. Sometimes might necessitate any neurosurgical input. What about prognosis? So the prognosis with the treatment is excellent outcome with very low recurrence rate, less than 10%, as we mentioned in RFA, without symptoms, without treatment, which could be with or without non-steroidal, because keep in mind we cannot keep a patient on a long-term non-steroidal anti-inflammatory drug because of the complication and risk from it. And even in the pediatric age group, we have to be more cautious about it. Long-term outcomes for return to function in most of the cases if it's treated, and minimal impact on the growth in the pediatric age group treated very early. So I'm going to present two cases we have done in Burjeel, one case done in Sharjah and one case done in Burjeel Medical City. So I would just give me 1 second, let me switch. So we'll start with the first case. So this patient, he is a 30-year-old gentleman who presented with severe right hip pain, and a CT scan demonstrate. Sorry, just give me 1 second. Get the CT. A typical osteoid osteoma. So this is the nidus and this is sclerotic area in the right neck of femur. He is young, he's active, and he is this pain causing disabling him with lack of sleep, affecting him mentally as well. And when he came, he just said, "Doctor, just take this out, whatever it costs." And he has the good thing he has done. He's quite educated. He's IT. He's done some research and he looked on the internet about options for treatment. And one of them is a minimal invasive treatment, which is radiofrequency. And that's when he came. So after we spoke to him and counseling him, we went went ahead for CT guided ablation. So maybe slide a few images here. So this is typical the needle of the radiofrequency. As we can see, this is the lesion there, and this is the RF needle within the lesion and causing the ablation. As we can see, it's quite minimal invasive. There is no wound, there's no cut, quite precise. There is with position we avoid any important structure like the femoral artery or vein or femoral nerve by just sending the patient in a way. We try to avoid going that way, or we avoid any going to the vein or artery. So by this way, we minimize risk of any injury to any vital structure. It took about 4 minutes for the thermal ablation, but more time to get to the lesion. These lesions can be very, very tough and very strong. In order to go through them, we use the drill to drill through it until we get the need thermal ablation. So sometimes surgeon argue, say, if you drill it, that's enough. No, that's not enough, because you destroy part of the nidus with drilling, but you need to destroy all the nidus. And this is when the thermal ablation comes, because there's so apart from the needle here, the needle side there is a thermal zone around it. And this we can control how big the thermal zone depends on the time and depends on the energy delivered. So the more energy, the more time, the bigger zone of ablation. By this, we ensure destroying the nidus. With this patient, like after, so he came with pain after we did the ablation. In the recovery, after a few hours, say, doctor, the pain has completely disappeared. Then I followed him up after a week and after a month, and he was completely asymptomatic, and I never heard anything about him again. I told him, if any problem, come back to me. So this is no-show is always good news. So I've never heard anything about him, which is more than a year now since we have done it. It was February 2024. The next case is also a young chap as well. He came with severe pain. This is very nice. This is a very nice case, because the pain he came with right iliac fossa pain, pain in the back. He was being diagnosed previously with rheumatoid arthritis, and he was on treatment for years without any improvement at all whatsoever. Then started developing right iliac fossa pain for a year. They been seen, CT scan, everything. They couldn't find anything. Then he started to believe that this is he had some like mental issues with his pain, because they couldn't find anything. Unfortunately, on this, I didn't get the CT scan and here today, but unfortunately on this patient, on the CT scan more than a year before, that the lesion as reported in the right iliac as just benign lesion, and that's the only comment. And he was suffering with pain. So at the time he was seen by orthopedic. Then they did some MR where we found an MR. This is the osteoid osteoma with the nidus, and there's some inflammation around it and some sclerosis as well. As you can see, there's not much inflammation. It's more kind of sclerosis here. But digging in history, he's got night pain as well. He tried some non-steroidal help, but not for long. Then he stopped it because he was worried about the using it. Without telling he had stopped it, but digging more the history, he said that he had stopped it and the pain has recurred and getting worse. Also he went, so when he came on the day procedure, he was in the wheelchair. He was so disabled. He lack of sleep. He was barely having 1 hour sleep overnight for many weeks. He has lost weight. He has in very bad shape physically and mentally. So he also went CT guided thermal ablation. We use microwave ablation, not radio frequency in this case. As we can see, the needle is maybe this image a little better. You can see the needle in the nidus, as we can see here. And he went thermal ablation. For this patient, it took some time. So after like a week or two, he visited me. He was walking. He still had some pain, but it was completely different from the pain he had when he came in a wheelchair. The right iliac fossa pain completely disappeared in day one. He said on day one that fossa pain has disappeared, but still has some back pain. Then the pain started improving, but hasn't disappeared after 3 months. So after 3 months, the pain, we said like about 85 to 90% disappeared, while the previous patient said 100% disappear. So that's what we can see. I think it depends where is the lesion as well, and it depends on the chronicity as well. The pain may not respond 100% to treatment. Then I told him after 6 months, he said he has gained weight. He looked brighter, back to work, back normal function. He said the pain is about 5%. And at that time, I told him you can use non-steroid anti-inflammatory drug. Between time and time, when he has some episode of pain, he can use non-steroid anti-inflammatory drug. We discussed about repeating imaging, but repeating imaging might not show much difference from what we might also going to see the osteosteoma. We can argue that MR can use to see if there's inflammation. We kept this in the mind, but after 6 months, it has been also now more than a year. It hasn't come back to me. So also I'm assuming this is that the pain either disappeared completely or he's living very well with it. Because we told him if that persists, we can do MR. Whether we go another RF ablation, that was questionable because there has been a lot of improvement of his pain. So what are the advances and research nowadays in terms of the treatment of this condition? Navigational RFA in order to improve accuracy and safety of the procedure, MR guided ablation for people who we cannot expose them to radiation like pediatric. Microwave, as I mentioned, we are exchangeably using microwave and RF cryoablation as well. One of the emerging way to treat these cases. And this research showed a 100% successful rate. Focused ultrasound therapy, FDA approved Sonarville device, which I haven't seen this device. It's in the state at the moment, and it's still under kind of although has been approved by FDA, but it's still not very widely used until now. Artificial intelligence, as every other area in the world, has its footprint, and it's also emerging area in the diagnosis of the condition. Biological markers studies underway to explore if there's any molecular signature of the osteoma. So to summarize this talk for this afternoon, osteosteoma is a small benign tumor with significant clinical impact on the patient. Particularly, these are the young age group, active group, presented with the classical nocturnal pain relieved by non-steroidal because of the prostaglandin. CT is the diagnostic and gold standard for diagnosis, and now is kind of gold standard of thermal ablation as well. Thermal ablation offers a safe, effective, and minimally invasive cure with a recurrence rate less than 10%. As I said, early recognition is a key factor to avoid unnecessary intervention and prolonged discomfort and suffering of these patients. And newer technology aim to further improve the outcome. This is my reference. Thank you very much. And any question and open for discussion.
Thank you, Dr. Mustafa. It was excellent presentation. You have touched all the aspect of osteoid osteoma diagnostic, intervention, and the recent advances. We have Dr. Mohammad Zaki, our intervention radiologist, as a moderator. Dr. Zaki, your inputs, please.
Thank you, Mustafa. That was really excellent. If you pick one procedure which is a show of interventional radiology, is this one, osteoid osteoma, because the improvement is dramatic and it's well supported by guidelines by orthopedic, American Association of Orthopedic, the radiology, the MSK Society in Europe. They all consider this a standard of care. So for our colleagues, radiologists or other clinician who's on this presentation, please, if you see any case, you know how to refer and where to refer to. This is becoming a standard of care. So please, the floor is open. Any question from the, if you have a question, just raise your hand. Otherwise, I will have one question, if that's okay, Mustafa. So if when would you consider biopsy?
Yes.
Sorry, Dr. Rajesh. Dr. Rajesh. Sorry, Dr. Rajesh, please.
No, just wanted to add, like the experience, like use of F18 bone scan. Any experience with use of bone scan? Because we did not elaborate that part, which is one of the most important thing for the diagnosis. Like as probably we are going for like whether we'll be proving the lesion that whether it's osteoid osteoma or not. Many times we'll directly go after confirmation. The ablation is done without even taking out the any like material for the confirmation, histopathological confirmation. So any experience with bone scans or any experience with that?
So in terms of bone scan, as I mentioned, specificity and specificity is less than cross-sectional imaging. We can use it. They're called the double spine. But as I said, that sometimes can difficult to differentiate between like a body abscess or other kind of cancer as well. Probably Amu can elaborate more because he's MSK. But the gold standard for diagnosis definitely is CT. Because in order to diagnose this, you can imaging based only as you see the nidus and the sclerotic reaction. MR is also important, but sometimes the inflammation is too much. You can obscure the nidus. I will go to Zaki's question. I think because this is also linked to this question is about the biopsy. So if we are not quite sure about the lesion, before we do the treatment, we do biopsy. And I think the more important is with the pediatric age group, and particularly to exclude a tumor like Ewing sarcoma or LCH. I think with the more like in the 20s and 30s, where the risk of cancer of Ewing sarcoma is less, and if we are confident based on cross-sectional imaging, we can do biopsy because the technique that we use coaxial needle. When we get the coaxial needle in the lesion, we can immediately take a biopsy from it. But that's as I said, like if we are very, very confident on imaging and not, I would say less, like between 50 and 30, biopsy is something we can do or will not do. But if it's younger age group, I think biopsy can be a must before we commit on the treatment. And as I said, we can do it on the same time. If we are having like high suspicious diagnosis of osteoma, we can do a biopsy and treat. But if not, we have to do a biopsy in one stage and do the treatment after confirming diagnosis in stage 2. And I think that the case Dr. Zaki did, and I did with him, the pediatric age group, which has excellent result as well. We have taken a biopsy also in order to prove it as well.
Hey, just experience what I had. One of the case had like a femoral neck lesion was there. So as we know that there won't be any sclerosis, just the lucency was there. And in that we used F18 bone scan where cross-sectional CT was also taken altogether. This was the experience which I had, and this was told to me by one of my nuclear medicine friend that F18 bone scan is a good where we are doing a phasic, like the blood pool phase is picking up the whatever the radionuclide, and they do simultaneously the CT cuts at the same level, though not as good as what we have, but definitely that gives a precise location, and the phasic change in the radionuclide uptake can definitely gives us the proof that this is the surely osteoid osteoma. So many times after proving that, only the interventional radiologist will take up for like where we are not pretty sure whether we are dealing with an abscess or with a osteoid osteoma at those locations, especially. That's why I had.
Yeah, I totally agree with you. And at the end, we take the whole picture. clinical presentation, gender, age group, imaging modalities, blood test, all of these take all in consideration. And if we cannot at the end find diagnosis, I think the biopsy is the final result, whether it's going to be as infection or it's going to be as a tumor or it's going to be as osteoma. So I totally agree with you. It is each they are all linked together. They all as a chain. So you have to take the whole picture all together. I totally agree with you. Yeah.
Yes, absolutely, Dr. Rajesh, what you are mentioning, particularly with the lucent osteoid osteoma, bone scan is one of the helping imaging modality. Nidus will be giving us the typical uptake, and the lucent part surrounding the nidus will be less showing less uptake, which is giving the typical double density sign, which we call it as on the bone scan. It is definitely helpful in the lucent lesions. Anybody is having any question? Dr. Mustafa, I have one question. Basically, there are different modalities for the intervention of osteoid on osteoma. Like you are usually doing the radiofrequency ablation. There are laser, there are cryoablations, microwave also used for the osteoid osteoma ablation. You have mentioned definitely RFA is the gold standard. But is there any differentiating points to plan these ablations based on the different modalities? Like any criteria you follow?
Yeah. RFA is the gold standard until now. It hasn't changed to microwave as all other tumor ablation. So whatever go to tumor ablation, always say RFA because it has a longer history. Microwave is emerging, it's taking over, as like you know. So most of our work we do with microwave because it's quicker than RFA. There's no other consideration. For example, the RFA you cannot do it with a patient has pacemaker. You have to stop the pacemaker because how it works. With the microwave, we don't need to do these things. So the only thing, because RFA you said the gold standard because that guidance has not changed, but in reality most of IR now is microwave. In terms of how we decide, so there are multiple factors. If the area is near critical and important region, we try to avoid thermal ablation because the heat will cause more damage. We use in this case cryoablation, which is safer, which is causing less damage. And usually the damage it causes, particularly to the nerves, it is usually temporarily. If it's for the vessel, it doesn't cause much damage because the blood flow is coming there. And sometimes we can, if it is very critical area, say there is no safe approach to do it, maybe go to open. So open is still on table, but this is coming to be in minority of the cases. So also availability. Sometimes the availability of the device, with the microwave or the cryoablation, whether RFA, the cost effectiveness as well. So some of them are more expensive than others. So all these are consideration. But generally speaking, if we prefer thermal, personally, and I think Dr. Zaki agree as well, we love our microwave now more. It's quicker. It is quite safe as well, and there is no other consideration like pacemaker or these other consideration. We don't look to it.
Thank you, Dr. Mustafa. Any other questions? If there are no questions, I would like to thank Dr. Mustafa for excellent presentation. Thank you, Dr. Zaki, for moderating this session. And I just wanted to mention all the delegates, Dr. Zaki and Dr. Mustafa, they are doing excellent intervention work here in Burjil Medical City. They are covering all the aspect of intervention radiology below neck. If you have any cases related to intervention radiology to be dealt with, they will be more than happy to support. Because at the end of the day, radiologist is the one who is diagnosing all these cases. And you just refer those cases to Dr. Mustafa or Dr. Zaki, they will be happy to support you people. Thank you.
Thank you.
Exactly, Dr. Amul. We do have a clinic, so we accept the patient directly. So if you find anyone CT scan, anything, you just forward the details and we will Take care. Thank you very much, Mustafa. Thank you, Dr. Amul.
Thank you.
That was
The
excellent.
other thing that we are 24/7 on call as well. So our phone is there. So whenever you call, we will reply. Sometimes we can be busy and doing the procedure or something. Maybe we can't reply immediately, but we will, like 99%, we'll go back and contact anybody has contact us. The other thing, just to mention quickly, that to Zaki as well, going to Al Ain, I'm going to Sharjah as well. So this is in terms of the help that we are providing for our colleague in different hospitals. Thank you very much.
Perfect. Thank you, Dr. Mustafa. Thank you, Dr. Zeki. Thank you all the
Thank you.
delegates for joining. Thank you.
Thank you very much. Bye-bye.